Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals, where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation, and over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before you get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started. This week's episode is a heavy one, but an important one. We talk about loss and grief that children and their parents face. We talk about trauma the children experience and the resilience they often demonstrate in the face of that trauma. And we talk about crisis and how technology can help some kids and parents navigate through it. I start by speaking with Dr. David Schonfeld. He's a developmental behavioral pediatrician who founded and directs the National Center for School Crisis and Bereavement at Children's Hospital Los Angeles. He is internationally recognized for more than 30 years of work supporting children, schools, and communities through grief, crisis, and trauma, authoring over 150 scholarly publications and providing expert consultation following major disasters and school crises. I then speak with Emma Payne, who built a text-based service delivering personalized bereavement and emotional support to parents experiencing grief after the loss of their children. Finally, I speak with Dr. Solfrid Raknes, a Norwegian clinical psychologist and researcher known for creating and leading evidence-based mental health programs for children and adolescents, including the Helping Hand and other large-scale interventions used internationally. I hope you'll find that despite the heaviness of these topics, that these leaders are finding hope and optimism in the work that they're doing to help children and their families navigate some of the most difficult moments of their lives.
So the National Center for School Crisis and Bereavement, which is at Children's Hospital Los Angeles, provides a number of services to schools and communities that have been dealing with crisis or loss. We provide immediate support in terms of technical assistance, consultation, and can give advice. We do that 24/7 every day of the year. We're available off hours as well. We also provide on-site support to schools that have had large-scale events to help guide them through that process. And all that technical assistance and support in the immediate aftermath, we provide at no charge to the schools or the communities. We also provide training. We do training for a wide range of different professional and non-professional audiences. We prepare material that help with prevention and preparedness efforts as well, and we do some advocacy and research.
So, give us some examples of the types of things you do in a crisis.
So, for example, after the World Trade Center attack, we worked with New York City schools for about 2 to 3 years to provide in-person training for all of the school crisis teams in every school. They had I think, about 1,200 schools at the time, and in over 40 of their school districts, and helped set up a citywide team that involved all of the schools in New York City. So that was one example. We more recently have been working with New York City schools initially during the pandemic. So we provided training for about 20,000 of their school staff through a series of approximately 100 live virtual webinars in the first year or so of the pandemic when they were the epicenter. And that was on how to support kids around the pandemic, how to become more grief sensitive to support students, and a number of them on professional self-care. And then more recently, we've been helping them with Project Open Arms, which was initially established, I think, more to work with the newest New Yorkers. So families that were seeking asylum and immigrants who were in New York City throughout the New York City school system. And so we've been working with them to help them think through not only how to do that work, but also how to support their staff, some of the challenges that they face. So this is an example for New York City schools, but we're working with the Los Angeles wildfire response and mass shootings across the country. So it's a wide range of things.
Give us the scope of your center and the kinds of people you impact around the world.
Yeah, so I've been doing this work for 35 years. The past 10 years or so has been in Los Angeles, but the number of events are actually quite high. A lot of it is we do the work behind the scenes because we try and empower local schools and communities to respond most effectively. So we're not in the camera, so to speak. We're not out in front. And we tend not to talk directly to students, but instead try and empower those in the community, whether it's in the school or the broader community, in order to be able to support children there because they really deserve support over time. We don't want to just fly in and talk to kids for 20 minutes and think that that's going to make the difference. So there've been a wide range of school shootings, unfortunately, a lot of them. And we coordinated the response for the first week at Sandy Hook. We worked with Marjorie Stoneman Douglas in Parkland, Florida. We went out approximately monthly for several years. We are working now with the Annunciation Catholic School in Minneapolis. We supported Saugus High School, Appalachian High School. I mean, it's a long list of schools. We don't just work with the schools. So we went out after the shooting in Mandalay Bay, for example, in Las Vegas, and we worked with Clark County Schools, but also the Nevada chapter of the American Academy of Pediatrics in Las Vegas, the city as well, to help provide some presentations and training. So those are kind of the school violence, but we also work with natural disasters. And so we've been out for a lot of wildfires, whether it's been in Maui or in the Los Angeles area or in Tennessee or in Butte County or Sonoma County. We've worked with a lot of hurricanes throughout the country and earthquake. We didn't have many large scale earthquakes here, but we went out to China to provide support after they had an earthquake that killed about 69,000 people. We went out for a number of trips there. We've gone out after tornadoes in Joplin and Alabama. And we also work with schools after suicides and suicide clusters, although we don't mention the names of the schools for privacy reasons. And we will work with schools that have other types of crisis events. A lot of our work is national because we don't really have the funding for international work nor the staffing to be able to provide that support throughout the world. But we have gone and responded to crisis events internationally. The stabbing in Akita Elementary School outside of Osaka killed, I think, 7 to 8 year olds and injured a lot of others. We went out there and we actually worked with them to help create a center on school crisis response for the country that was located in Osaka. We've gone out and helped. A lot of it is through national meetings and presentations. Went out to Italy to consult on Ukrainian refugees dealing with trauma and loss. They had one of the largest European populations of Ukrainian refugees. A lot of that is also virtual, like in Israel around the current conflict there. And we did some support around the pandemic internationally as well. So we do a fair amount of work internationally, but we have to be invited in by a nonprofit to support the travel just because it's expensive.
Are the tools that you're offering, the training you're doing somewhat similar in terms of how you help these communities respond, or is it very customized based on the type of crisis that occurs?
So it is quite customized. That's intentional. So it is customized both on the unique nature of the crisis event, but also on what that school or community or organization would like help with. We don't come in to try and implement a program. We come in to help. And so we might go and respond to a school shooting, mass shooting, for example, but find that they have a really strong mental health agency that's working with them. So then we don't focus as much on that and we focus instead on consultation and support for school leaders, or maybe we work with the families to talk about commemoration, memorialization, whatever the unique challenge is for them. And a lot of what we do that I didn't mention is really support for leadership. It's really hard to lead during a crisis event. So we will kind of partner with the leaders. And we do that on a confidential basis, but it allows them to speak with one of us at night or on the weekend and talk about the challenge that they're having or some of the effect it has on them personally as well as professionally. We also do create models. So we've instituted different models for kind of academic supports after a mass shooting, or we've started a process of recommending recovery coordinators for a school or a district. We've also recommended in certain situations that there be a designated person for employee assistance. Because if you think about it in a school in particular, but it's also in healthcare settings, the children are clients or patients. And so the school is set up to take care of their needs. They may not do it as well as you would like, but there are mental health providers to meet the needs of students. The teachers and the school staff are considered employees and they're supposed to be healthy. So if they get mental health supports after a mass shooting, for example, that's usually arranged as a benefit through HR. So they're told this is where you can go to get the help, but there isn't any help here for you because the help that's in a school is for the children. And it's the same way in a healthcare setting. But Children's Hospital Los Angeles, for example, has recognized that we really need to provide psychosocial support to its staff so that they can thrive and do as well as possible. So CHLA is kind of one of the leaders in implementing best practices on physician support and other healthcare provider support. So we're trying to do something similar within schools as well.
Have you ever had to navigate the moral injury of first responders or teachers, caregivers who may have had to do things that are counter to their beliefs through a crisis or counter to their core principles?
Moral injury is happening more. I don't think it's just that I notice it more. I think it actually is happening more. So you're finding a lot of people who are either asked to do what they don't feel is best practice or appropriate, but they are also not allowed to do what they really feel they should. So as soon as you say to someone, you're spending too much time providing emotional support, I really need you to get back to academics, or I need you to get back to your job or you're not being efficient. I remember during my residency, there were situations where I was discouraged from doing what I felt I wanted to or needed to do or was morally drawn to do. Because if I talked with the family about the sexual assault that the child went through, there were situations where I was told that's what the social worker does. You need to move on. You're not being efficient enough. And that causes moral injury when you feel you're not doing what you ought to do or not permitted what you would like to do and think is needed most. So we do spend more and more time now talking about how do you minimize some of that moral injury? What strategies do you use? Because moral injury is going to lead to burnout or decisions to leave the profession, or it just makes you depressed or feeling less efficacious.
Recently, with the shootings at Brown University in Rhode Island, there were stories of students who've been through previous crises like shootings in other schools. So now you're seeing a generation of children who are going through multiple crises. Talk to me about resilience. We hear all the time kids are resilient, they grow. How does that factor into your approach towards crisis support? What about post-traumatic growth? You've talked about that a lot in your talks as it relates to how you think about the trajectory of a child who's experienced a crisis.
So first off, it's important to kind of understand what resilience is. So resilience means that people have the internal capacity to be able to cope with adversity without external support. It does not mean that they're not bothered by it. And I think that's one of the confusions. People say, well, children are resilient, they'll get over it. Actually, most people do recover, but it doesn't mean that they don't suffer. And it doesn't mean that it isn't difficult for them. There's a saying, the Buddhist saying, that pain is inevitable, but suffering is optional. What we're really trying to do is to recognize the fact that it's difficult, but we want to build the resiliency so people could cope without external support, at least for a time period. But they still should be offered support. They still should access it and accept it. So, healthcare providers, for example, are also very resilient, but that doesn't mean we shouldn't support them in the difficult work that they do. So first off, resilience sometimes is viewed as an excuse not to provide support, and that is a misunderstanding, in my opinion. So really, kids are resilient, but that doesn't mean we shouldn't be helping them during these times. And so part of what we find is that there's a lot of discussion about the fact that trauma has this effect on the brain. It changes who you are. That adverse childhood experiences can change your trajectory for the rest of your life, can alter your health status when you're adults. But the reality is that they are difficult, and we do want to minimize adverse experiences for sure. but the majority of people do recover even if they don't get treatment. That we need to emphasize to people that just because they're in difficult situations does not mean that they've been damaged. I was talking to someone in Israel right after the attack in October, and the person just said to me, "What bothers me most is I think we have now a whole generation of children who are damaged for the rest of their lives." I said, "They're not damaged. They're negatively impacted. They're suffering. We should work with them to try and help them, but most will recover." And some people actually emerge, not the majority, if they have enough internal resiliency and sufficient external support, they may actually become more capable. They may become more spiritual. They may be more empathic of people. They may devote their life to a career that helps others. We see that a lot in the healthcare field. A lot of people go into healthcare because they were sick as a child or they knew someone who was, and they want to devote their life to helping others. So that we call post-traumatic growth. And that's the best outcome you can have after a crisis. First off, it doesn't happen to most people, and we should never hold that as an expectation. Most people, we expect them to recover, and that should be their goal. But some people will go beyond that. So I often tell this one story that I was talking to a group of foster parents after a large natural disaster. And I went over what post traumatic growth was. And so one father raised his hand and he said, "I think I went through that." So what happened was he was happily married as a young guy. He worked on Wall Street. He was very successful financially. He had a toddler who he loved, and he thought everything was going well in his life. And the toddler got sick and died. And he started to question what he was doing with his life. And he said, "I questioned everything, and I even questioned what I did for a living." And he said, "I make money for people who have money. But to me, that's a job. A career is something that changes the world in a positive way. And I don't do that in my job." So he quit his job and went back to college to become a kindergarten teacher. He said, "Changing the life of a young child, that's a career. It's not a job." And then he looked at me and he said, "Is that post traumatic growth?" Well, the answer is yes, it is. He also was a foster parent and he was starting adoption proceedings for his foster child. So he really had changed as a person in ways that I think most of us would say are positive, and he felt more fulfilled. The problem is that's you have a lot of people that go into early education and education because they're really driven to help children in need and to help them grow. And you see that in healthcare. The problem is that when you do help people in need, it often resurfaces the prior trauma and loss that you had as a child. So the very thing that puts us into helping professions is the thing that makes us most vulnerable to being hurt by helping others. And that's why the moral injury, compassion fatigue, vicarious traumatization, all the impacts on the helper are really important to try and minimize.
And then in these helping professions, do you think we have the support for those employees, those staff to help them for those who may have experienced trauma in the past as part of their journey?
Well, we can, and I think we ought to. And I think some places do it. And I actually do think Children's Hospital Los Angeles does it to a greater degree than most of the places that I know. A lot of what we do in professional fields is to try and help the professionals learn how to take care of themselves. It's all about professional self care. If you're upset, it's because you don't know how to do mindfulness. You don't know how to do these other techniques for self calming and regulation. And the issue is professional self care is important. We do training on that as well. But organizational support is even more important than the professional self care. Otherwise, I worry that we're blaming victims. We're basically saying to them, if we put you in a really difficult job and we put high demands on you and it bothers you, there's something wrong with you. You need to fix yourself. And so I do believe we all need to learn professional self care strategies, but we also have to have organizational support. And most places don't do that well, but some places do. And the fact that some places do should make us all realize we could do that everywhere.
So this work you do is both inspirational. I imagine it's also very challenging. What motivates you after 35 years? What motivates you to do this work?
A lot of people ask me, why am I doing this? Because I had a traditional academic career in pediatrics. I went into pediatrics because I loved kids. I wanted to be with them and I wanted to help them. I was a fellowship director. I worked in clinical programs. I attended in the inpatient unit in the emergency room, and I ran a lead poisoning program for 15 years. So I did all of these things, and then I became a division director and then a department chair and a pediatrician in chief. The work that I was doing in the school crisis response was something I just happened to volunteer for during my early training. And people kept asking me to do more. So I just kept doing it. But I always considered it something that I did on the side. People would say, "Why would you do it?" And I'd say, "Well, some people after a crisis donate blood. I don't like doing that. So I donate my time and I just try and help." The problem was that got bigger and bigger, and I kept being asked to do more of it. And then I created a center and I got funding. And I realized I actually couldn't do both. I couldn't be a pediatrician in chief, but also be leading responses after major crisis events. So I made the choice, and that's why I chose to do this work. But to be quite honest, I had the worst business model. We come, we're available all the time, we volunteer, it's free, and we help. And that's really hard to sustain and to grow. And so I guess I'm in the position now just because I felt it was worthwhile. And now I have to try and figure out, okay, how do I sustain this, grow this, institutionalize it, build the scope so it isn't just a small group of us trying to help the country, but instead we're figuring out how to make this replicated and be able to do it more broadly.
Dr. Schonfeld, thank you so much for your time and all the work you're doing to help communities and individuals recover after crisis. This is a unique space you're in, and I'm really interested to hear how you got here.
Like most people in bereavement, there's a difficult backstory, but I had been developing web and mobile solutions for about 20 years, focusing on things like youth voter registration, care coordination, lots of other different kind of community-minded projects, suicide prevention. And then my friend died. And it was my first time being with somebody at bedside, and he had asked me to deliver the eulogy at his funeral, which of course I agreed to do, but it was a pretty challenging ask because he was the best friend and also second cousin of my husband who had died a decade prior by suicide. What essentially happened is that I flew across the country to deliver the eulogy and spent the whole time hearing people saying, "I'm so sorry I didn't reach out when Barry died. I didn't know what to say. It was my first time hearing of someone who had died," and so on. So on my plane ride back from the funeral, I just thought how crazy it was that I had spent 10 years not hearing from people. I was 19 when I met Barry, my husband, and 31 when he died. So it was very difficult to not hear from college friends and all the people in my life who had just found it too difficult back then. So it was sad that I hadn't had the support, but it was also sad that 100 plus people had spent that same decade feeling badly about it, feeling ashamed that they hadn't reached out. And as I said, I already had about 20 years web and mobile experience at that point. So I really used my whole plane ride back from the funeral to think, what would be the simplest, cheapest, most effective personal way to get grief support to every single person who wants it, and to let friends and family who want to help have some suggestions for how they could. So I mapped out what became help texts on my flight home from that funeral. Now we're supporting grievers in 57 countries and all 50 states, and very proud of it for sure.
Thank you for sharing that. I can only imagine what that must have been like. I know it's difficult to relive, so thank you.
We've worked very hard to feel comfortable and competent in the most difficult of situations. So we work with all kinds of leading experts in childhood bereavement and parental loss, child loss, to craft messages that are tailored based on all kinds of things.
What are these messages that you have? Walk us through what this actually looks like.
Our content is all human created and proudly so. In fact, we've been through a verification process to give people comfort about that. So we have over 100 expert contributors around the world who are deeply expert in bereavement. It's not just people with a single lived experience, it's people with all kinds of letters after their names, thanatologists and neuroscientists and so on. They have expertise in lots of different areas of bereavement. We work with them to craft the texts, then go through with the thanatology lens to make sure they're really carefully vetted. And then we send them out to grieving families based on what we know about their loss. So let's say dad has had a child die in a hospital. They get care from the hospital. They sign up and they tell us the name of their son, how old he was when he died, what his birthday was, things like that, what he died of. And then he will get texts based on cause of death and relationship and so on. So, yeah, the texts are very much human created. And
Yeah.
then our use of AI is on the back end to just help us get really good at like crisis detection, for example, sentiment analysis to see how people are responding to messages so we can get even better at tailoring what we send.
So let's start with text, though. Why text messages?
It's very accessible. We can send in multiple 27 languages. You don't need a smartphone. You don't need a Zoom connection. Right? It comes straight to your pocket. You've already got lots of emotional burden going on. So we do the work and we come to you. There's also some interesting neuroscience around text specifically. So when we get a text message, unlike when we get an email, we have a little dopamine lift. The dopamine lift helps us feel cared for, increases motivation. So I think that accounts for this massive engagement rate that we get where people say, thank you, I'll try that today. Yes, this is helpful. They're very engaged with it because text gives them that little boost in the first place. So yeah, super accessible. And also it just feels good and feels personal and does all the work for you, right?
Is it bidirectional text?
It's one-way texting. That's what keeps it scalable and affordable and lets hospitals and tissue banks and hospices and so on deliver that full year of support. It's interesting though, we have very high acceptability rates with men, above 95%. So men are less likely to sign up. They make up about 20% of our global subscriber base.
Do you have any kind of outcomes data to show? Do you have anything more that shows the value it's creating or producing for families?
That's what we're working on this year. So we have a couple of big studies published, including 2024 in death studies, which was a big deal, had a large N. So that was showing acceptability, retention, things like that, qual and quant data. This year, we're trying to get to outcomes, both cost and health outcomes, because we know that when people are grieving, when parents are grieving a child, especially the case that we're looking to, of course, have a positive impact on things like depression, anxiety, substance misuse, suicidal ideation, and so on. So we have a couple of studies going on this year, one out of University of Miami with Wendy Lichtenthal and one with Mary Frances O'Connor at UCLA, trying to get to our outcome data this year, which will be great. Anecdotally, I know that it works. We see people constantly telling us, so our feedback is through the roof. That's what's been published. I know we've saved lives, but it'll be nice to get that kind of information.
I heard you're doing something with Arkansas children.
That was our first children's hospital. We originally began with hospices because, of course, hospices in the US are required to provide 13 months of bereavement care, and then extended to OPOs, tissue banks, who also do quite a lot of work, what they would describe as donor aftercare, so providing bereavement support for donor families. And now it's been exciting to extend to children's hospitals. So for Arkansas Children's, they're looking for a way to make sure every single grieving parent can receive immediate expert grief support tailored to their loss for a whole year. And they're providing it to families now when their child dies in their care. It's a powerful thing, of course, for families that there's no wait list. It's here for you whenever you're ready. We're in 27 languages as well, which is helpful because a single bereavement coordinator can't provide that kind of care, can't remember everybody's birthdays and death anniversaries and so on. But the other benefit that we quickly see is that the staff themselves, it reduces their stress and anxiety because it's a difficult feeling to care for a child and then not have anything for the parents when that child dies. So it also gives them something that they can in turn gift and for very little money be able to know that every family has something when they walk out the door.
Are most of these patients battling an illness and they've had it for a little while and then they die? Or do you also help families navigate sudden, surprising deaths?
We began because of my own suicide loss. We actually began in suicide, sudden traumatic. In retrospect, it's a strange arc, but we sort of started with the really difficult, the times when people are most alone and the least likely to be able to find support. So, yeah, we have support for all causes of death. So, different messages for someone who's lost a child to suicide than someone whose baby was stillborn, than someone whose child had an infectious disease in the care of a hospital.
What about siblings? I imagine there could be an older sibling or somebody who is old enough to understand and process and perhaps even engage through text messaging. Do you support them as well?
We do. We have some experts who we work with specifically who focus on sibling bereavement. We text people 13 and up. And then we also have texts, of course, for parents or anybody grieving the loss of a child. But in terms of who can receive our texts, we're very comfortable 13 and up. My chief clinical officer actually has 20 years experience in teen bereavement and trauma. So our teen series is really strong. Texts are a bit shorter, a few more emojis. We work with people like Dougie Center to craft messages for the teenagers' Bill of Rights when they're grieving. So yeah, we have really nice support for siblings that is private. It's just for them. It comes to their phone. I think that tends to be often overlooked, and it's a difficult thing for siblings to not only have lost their brother or sister, but to also see their parents in this kind of pain, and it feels as if you're losing them as well. So we'll text a
Wow.
lot, try to support
That's
them.
great. Well, I still think there is a tremendous amount we as humans can do to help navigate grief, but I'm very grateful that you have taken a great swing at it with what you're doing and
You.
excited to see the outcomes come out and continue to stay in touch to see where this journey takes you.
Thanks for having me.
Tell us about the origin of the Helping Hand game. What inspired you to create it?
The start of the Helping Hand idea was that the school health service and the mental health service I was working for at the moment, they asked if I could come and teach the adolescents something that made them able to not come back when they were like doing education abroad. Because often I saw that adolescents didn't deal well with the difficulties, the breakups with their boyfriends or girlfriends, or like these things that happened when they were schooling abroad. And then I came up with this idea of putting the CBT principles into a hand and giving with them this problem solving strategy. This was the start of a booklet, and the psychosocial program became popular in Norway, in schools and in school health services. After that, we were thinking, maybe this could go digital.
But at some point, you realized that it impacted children with trauma.
Very much innovation happens by chance and from passion. And the thing was, at the end of my PhD, I was invited to do a little work in Lebanon with services that already had started using my program as a booklet, because at that time it was translated to Arabic. And I found it interesting and fun. And then we worked more on the feasibility of this program, like for Syrian children in refugee camps. So instead of being in Lebanon for 6 weeks, I ended up with staying there basically for 5 years. And during that period, we worked a lot with the booklets and with the programs that we could use in refugee camps. And then we did user testing and feedback and all of that, both with the Syrian refugees on the border to Syria, but on the Lebanese side, also with Palestinians and Lebanese adolescents, and also back home in where I'm from, both in the richest parts of the richest cities and in more heterogeneous areas.
So, how does the game work itself?
Whether they're here or they're struggling with many of the same problems. So part of what we did was to ask the adolescents in different settings, what would your dream application help you with? So I went into this classroom with refugees in Lebanon and in Norway, and they voted digitally and in Lebanon. And on that base, we came into 10 themes. And one theme is like one playground, so to speak, in the game. For example, the first one is how to give a school presentation, because the problem was, it would be wonderful to learn how to give a school presentation without getting so afraid. Because that was what my dream application was, to help me with, like not getting so scared when I'm giving this presentation. Other themes that were popular and came up was how to deal with criticism, and also how to deal with bad memories, and how to deal with suicidal thoughts. So then we structured this in a way so that it was possible to teach it like in classrooms and in groups of lessons. Because one thing is when you are using it on your own, basically you ask, how does it work? It works as a normal game, right? You meet some people, you help them to tackle their challenges. and these people you meet, they have different problems and you help them. And in this way also you learn about lots of different things. And in this game specifically how to deal with these high frequent mental health issues for adolescents. These problems are very much the same across borders, both national borders and digital borders and economic borders. Of course, it's not all adolescents who have own personal very bad memories, like traumatic experiences that leads to PTSD, and it's not everybody who has suicidal thoughts, but nearly all adolescents have friends with these types of problems. What we have found working in the harshest areas in Lebanon with the adolescents with highest amount of trauma, and this is partly the same like when we used this game in Odessa right after the full-scale invasion. The adolescents, they really get into this game. Like what we found in Lebanon in our biggest study, it was with 1,234 adolescents, and we had about 2% dropout. This is, you never find that in group programs with 10 sessions with adolescents normally. And we found like queues of mothers who wanted their adolescents to be part of these groups afterwards. This game has never become that popular in Norway, but when we have used it in groups of adolescents in areas where it's much more normal to struggle with the bad
So,
memories than not doing that, it's really like even more impactful than with high functioning adolescents who have all types of resources.
so in terms of trauma-informed care, do you see a future for digital tools like this for other interventions or research?
Absolutely. There are so many possibilities to help. Like in Ukraine now, when I was there and I heard children using this magic mitten game for smaller kids also out there for free, and the adolescents using this helping hand in the bunkers. Because you don't go and pick up a book from the bookshelf when you are running down in the bunkers, but typically you do have your phone, and they were using them, have nothing to do. They feel super scared, and then to work on coping strategies in that period, and then using that as a type of a conversation with their mother. Typically it's the mothers in these situations that are supporting, or with other children or adolescents. I've seen a lot of that. So I think that is one part of it. The other part, after we have seen this big decrease in anxiety and depression, as we have done with the Syrian refugees, and the feedback on this helps us to cope better, and it helps the Syrians know when they are moving back to Syria, like being more like building the country. Of course, technical tools like this is powerful tools. It's super powerful. Of course, it's here to just be scaled up, and not only for the rich kids, but for everybody.
So you're seeing kids use these in Ukraine. You're seeing them in Syria and Lebanon. Walk me through all the different places you're doing work around. Obviously, Norway is where you started. Where else is this being used?
Yeah, Jordan, Greece, but no, on the Magic Mitten side for the children, we have a fun project there in Gaza. That's with the Dr. Riyad and his group of people there, and they are doing very, it's heartbreaking there. Like it's really nice what they are doing there right now. And basically also the same using
What are they doing? Yeah,
and
tell us more about what they're doing in Gaza. Yeah.
yeah, so they collect children in the safest places they can, like, and not too many children at a time, like 15, 20 they use there typically. And there they use this magic mitten game. The same as helping hand problem solving, like the situation here, like what's up, and here it's feelings, like what do I feel? The red thoughts, we call them, like easier to remember when it's there, which are like the negative automatic thoughts if we are thinking CBT, and the alternative thoughts here, and what can I do and who can help me? So they teach that. But in the Magic Mitten, it's for children 8 to 12, and then it's like story, and they're telling the story, and then you come into the playground of the game, and they're doing these games partly digitally and partly just analog. What touches me the most from there now is that the children say, this is kind of a school break, a break from the war, like a little pause. And the small films I've seen, and the children I've heard from more personally that when it's so rough around you all the time and you are so scared, it's wonderful to have at least small little breaks. And that also is so healthy for the brain, for developing children and adolescents. It makes a big difference.
All right, thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and thank your crossing guard. And if you're so inspired, donate to your local children's hospital. All right, see you next time. The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast. CHLA does not endorse the views, opinions, and information presented on this podcast, and CHLA specifically disclaims any legal liability or responsibility for the podcast content.